retrieve the ovary before 36 hours, before 34 hours, or after 36 hours. So you're unable to retrieve the ovum from the ovaries. Okay. So coming to the ovulatory cascade. So whatever the time, that 34 to 36 hours, which is present from the LH surge. So what are the events which is going to occur during this time? Which is known as ovulatory cascade, which involves a meiosis resumption. The oocytes, which is going to be arrested, the meiosis 1 is going to recover, and they try to enter into, they're going to complete the meiosis 1, and they're going to arrest in metaphase 2. Next thing is follicular rupture. The walls of the ovarian follicle is going to rupture, which is an inflammatory process involving the prostaglandins and proteolytic enzymes. And regarding the context of this follicular rupture, there is one condition known as LUFS. So what is LUFS? LUFS, luteinized unruptured follicular syndrome. So there is a condition where you're going to have, an LH surge, but failure to ovulate. So especially by using of these prostaglandin inhibitors and your NSAIDs. So whatever the different NSAIDs like ibuprofen, naproxen, so which you're going to take for as a natural painkillers, especially during the period of ovulation. So which is going to suppress the synthesis of prostaglandins and which prevents the follicular rupture, which may leads to an ovulation. Okay, that is an important concept which you have to remember. So next is once the egg is released. So what happened to the graphene follicle? That is corpus luteum, luteinization. Okay, so that is the yellow body where the granular cells, they're going to previously which try to produce the estrogen. Now they're going to start producing progesterone for the next phase, that is luteinizing luteal phase. And the next is cumulus expansion. So whatever the hyaluronic acid which is released, which facilitates the ovum to be entered into the fallopian tubules. So coming to the luteal phase, so which is the phase which is responsible for the preparation of the implantation, the main function of your corpus luteum. Okay. So in case of a follicular phase, so estrogen is the main star, whereas in case of luteal phase, your progesterone is the star. Okay. So which is mainly under the influence of your progesterone release from your corpus luteum. Okay. So you're going to reach the levels that are going to reach nearly peak by the day of 21 to 22 days. Okay. So the function of the progesterone is to convert the endometrium from proliferatory phase into a secretory phase. So which is making the endometrium suitable for implantation. Okay. It is something like sowing a seed in a fertile, rich, moisture-rich soil. So this is the function of a progesterone for pregnancy. So you try to maintain the endometrium suitable for the following implantation of the embryo. Okay. At the same time, the progesterone, which is going to have negative feedback mechanism, we try to inhibit the hypothalamic neurons and decrease the release of further FSH. So the important point is regarding the luteal phase duration, which is fixed, that is 14 days. Okay, the normal lifespan of this corpus luteum is 14 days. So that is, it is designed like that. It can survive only for 14 days. And the only thing which can extend the lifespan of this corpus luteum is your HCG, which is released whenever there is successful pregnancy. Okay. So by any means, if there is no pregnancy, somehow you fail to implant, okay, fail to conceive, then what happens? The corpus luteum, which is designed only for 14 days duration, now it's going to undergo regress. Okay, so which is resulting in decrease in the secretion of your estrogen and progesterone levels. So whenever these levels are going to drop, which is resulting in two important events. One is beginning or initiating of your menstrual cycle, and at the same time, decrease in levels also releases the HPO suppression, and once again the FSH levels will increase and ready for your new cohort of antral cells, follicles for the new cycle. Okay. So that's about the hypothalamo-pituitary ovarian axis and the feedback mechanisms. And this axis will not be completed if without discussing about the kisspeptin neurons, which is our integrator of the entire system. Okay, so the modulators or the gatekeepers is kisspeptin. Okay, so in your hypothalamus, we are having two important areas known as arcuate nucleus and the AVPV nucleus. Okay, so in case of arcuate nucleus, which mainly mediates the estradiol negative feedback mechanism, whereas coming to your anterior ventral periventricular nucleus neurons, which mainly regulates your positive feedback mechanism under the influence of estradiol. Okay. So what is the significance of this peptine neurons? So these are the neurons which integrates the different signals, which is related to your hormonal, metabolic, and environmental conditions. So the question comes, why stress causes irregularity in the cycles? Okay, because the entire axis is going to integrated by the help of your kisspeptin neurons, which is going to modulate whether to facilitate or to stop your reproduction. Okay. So the most important integrated signals are your metabolic and your stress signals. So coming to your metabolism. Okay. So normally pregnancy is a expensive process, not in terms of money, but in terms of energy. Okay. So if you're going to consider a condition like if you're in a deep famine, or you're in a state of deep depression, some stressful condition, generally we are not going to plan for any pregnancy. Yes, sir. Of course, we cannot control our desires, but still our brain is designed such that so the main priority of your brain or your human body is to survival rather than reproduction. So this is the important part of our evolution. Our evolution is mainly to survive. The first priority is survival. Okay. So in the absence of proper reserves of food, okay, what happens? So the brain is going to shut down the entire axis and prevents and reproduction. Okay. So the important signal is your leptin. So which tells about indicator of your fat reserves. Okay. So conditions like anorexia nervosa, or in case of athletics, which are having low levels of fat, or during the severe starvation stages. Okay. So there is decrease in the fat levels. So which is going accordingly, we're going to have decrease in the levels of leptins. So leptin, as you show, so leptin is a stimulant for your kisspeptin neurons. Okay. So lesser leptin leads to decrease in the suppression of kisspeptin activity and decrease in the release of GnRH. Okay. And whereas coming to the other pathway, that is stress pathway. In all the stressful conditions, okay, there is increase in your corticotropic releasing hormone, cortisol. All these things are going to inhibit this axis via kisspeptin neurons. Okay. So the important clinical point is why the stress affects cycle. Okay, the logic is your brain gives priority for your survival rather than reproduction in all stressful conditions. Okay. So that's about the axis and the integration part. Coming to the little thing regarding the clinical application part. The first thing is your PCOS. What is PCOS? What is PCOS? Polycystic ovarian syndrome. So what is the important triad of this syndrome? You can observe. So problem is switch in your pulsatile nature. There is sudden change in your pulsatile nature. So what is the normal pulsatile nature? A low pulsatile which favors FSH, which is responsible for development of your Graafian follicle, where there is sudden shift from low to fast response. So instead of FSH, now we are producing more and more LH. Little FSH, so which is resulting in low FSH leads to underdevelopment of your follicles. Okay, there is no proper development of follicles. They're going to be in immature state. At the same time, increase in LH levels, which is going to causes luteinization. At the same time, which is going to produce more and more androgens. So you're going to see all the virilization features in case of PCOS. At the same time, insulin resistance, which is going to accelerate or amplifies the effect of LH. So basic treatment modalities regarding the PCOS is metformin, which try to decrease the insulin levels, okay, and try to lower the accelerator effect of on LH actions, and letrozole. So what is letrozole? So drug which is an aromatase inhibitor, which decreases the conversion of androgens into estrogen. So lower the estrogens, negative feedback mechanism, more is the FSH. So greater the FSH levels, greater is the way you're going to develop more and more follicles, better follicles you're going to develop. At the same time, lifestyle modifications which try to decrease the insulin resistance and increase the leptin sensitivity, so which is going to restore your natural pulsatility. The last thing is the comparison between your hypothalamic amenorrhea and premature ovarian syndrome or insufficiency. So what is the common point in these two conditions? That is amenorrhea. So common presentation is amenorrhea. But what is the difference? The level of problem. So in case of hypothalamic amenorrhea, the problem is at your higher centers. Okay, so mainly there is some GnRH depression. Maybe problem with your pulsatile nature, or stress factor or depletion of energy reserves, everything is going to affect your kisspeptin neurons, so ultimately causes your GnRH suppression, which may leads to anovulation and amenorrhea. Whereas in case of premature ovarian insufficiency, the problem with your gonads, you're having an intact hypothalamic pituitary content, normal functioning, but the problem with your gonads, so you're unable to release the ovum. Okay. So the treatment is either hormonal replacement therapy. In case of desire to fertility, you're going to go for donor oocyte. Okay. So coming to the key takeaway points, 5 important physiological principles which you have to remember. First thing is your pulsatile nature. That is the most important point. Okay. So continuous release of GNRH leads to desensitization of the receptors, and you're going to lose the function. At the same time, increase in the rate favors LH, decrease in the rate favors FSH. Point number 2, that is estradiol dual personality. So whenever there is high sustained levels of estradiol, greater than 200 picograms per ml, so there is sudden shift from negative feedback mechanism to a positive feedback mechanism, which favors your LH surge. And point number 3 is time is precision, that is ovulation. So which is going to occur 34 to 36 hours after your LH surge. Fourth is luteal phase fixation. So fix the time of your luteal phase, which is 14 days. Okay. So whenever there is variation in your cycle, that is mainly affecting because of your follicular phase rather than your luteinizing phase. Okay. And point number 5 is ultimate regulator, that is your kisspeptin neurons. So which try to modulate whether to permit or to arrest the reproduction by taking different signal input from different areas or different signals like metabolic signals, stress signals, and environmental factors. Okay. And coming to the final keynote. So in your daily practice, when you're going to think about some menstrual irregularities, so you have to ask a question, where is the problem? The problem is at the level of hypothalamus, or pituitary, or ovarian, or with the problem with the feedback mechanisms. So ultimately the physiology which provides the answer for your treatment. Thank you. So thank you. So I thank the organizing committee and the institute for giving this opportunity.
Thank you, sir, for clearly and concisely explaining the complex interplay of HPO axis and hormone mechanisms. We are now open for discussion. So, with deep gratitude, we present a memento as a token of appreciation, sir. We request our beloved HOD ma'am to present the memento. So, to set the tone for today's CME, I now request our Dr. Ramarao, sir, Emeritus Professor, Department of OPG, to deliver the opening remarks.
I welcome all the postgraduates at this regional CME conducted by the NTR UHS. And my greetings to the HOD, Dr. Yavati, and Dr. Aravind, and our coordinator, and our physiologist and associate professor. So this is a very interesting, complicated subject. When we were students, this is very zigzag pattern to understand this reproductive endocrinology. Reproduction is a vital point of a living being. When we are studying biology, the differences between living and non-living. So the reproduction, unless you know the reproductive pathway, so it is nothing but interplay of intrinsic hormones. Interplay of intrinsic hormones. So if you don't know the hormones, definitely it harm one. Hormone means harm one. If you are not understanding, if you are not using properly, it will harm one. And another thing is, so many, or you understand this, we are clinically we are facing so many problems like menstrual irregularities, like from amenorrhea to AUB, so many things are there, Now, these hormones you must know. This hormone study and how they are acting, this is very, very important. And recently, the thyroid also playing a role. Previously, we know, but due to lack of facilities, we are not doing this hormonal profile and other things. We, for everything, we used to send to Hyderabad or Bombay in those days. But now we got facilities and we are able to get the test done. So recently, I think in 1995, All India conference, the lot of light on the thyroid also. So these thyroid problems are becoming more and more. Previously, it is 0.2% that they are increasing. Because not increasing, we are not identifying them. So then we started. So in the antenatal mothers, we are regularly doing the thyroid profile so that we will not miss anything. So this another thing is amenorrhea is also a very difficult task. When we used to say amenorrhea is an intellectual exercise. It is an intellectual exercise because so many things are there, whether it is a hormonal problem, it is a chromosomal problem, or the congenital malformations, any inside or outside. These are all the things in primary amenorrhea or secondary amenorrhea. So slowly, by understanding this endocrinology, now the endocrinology has become a subspecialty. Do you know or not? I don't know. There is MCH endocrinology. So that much science has evolved, and to give good solutions, if you know the hormonal profile and other things, you can give a better solution as a clinician. That is my appeal. Kindly understand the hormonal profile. See, nicely you have known the menstruation, what is the menstrual cycle, what is negative feedback, positive feedback, if it is excessive, what is there. These are all the things you must know. Then only you can proceed further. What is the cause for precocious puberty? What is the cause for amenorrhea? What is the cause for lactational failure? So lactation failure, generally everybody thinks you are not eating well, you are not. It is justly mostly due to after delivery PPH, the lactation failure will be there. Generally, it is due to Sheehan syndrome. Don't think textbook description of Sheehan syndrome will not be there. Probably it may be a partial Sheehan's. Probably she might have lost a lot of blood where you are not replacing. Or another thing is the relatives are not giving even water also. So the Sheehan syndrome also like that. If you know the pathophysiology of any disease, you will be becoming a good doctor and a good clinician, and you can treat better. These are all the things. Anyhow, I wish that you can learn more by listening to the so many speakers are there. I don't want to take away much of your time, and I hope that you will enrich your knowledge. Thank you.